Okay, you may proceed. I think I'm recording it.
Okay. Can you see my screen?
Yes, sir.
We can see it.
Okay, so good evening, colleagues. To this week's tutorial. Like we said, we'll be looking at anesthesia and IC alternate weekend rather. So today we'll be looking at anesthesia breathing system. These are basic anesthesia topics, and we just remind ourselves. I'm sure many of us are familiar with the details in this presentation. So it will be a discussion like, and we will also remind ourselves of some very nitty-gritty of the topic. All right, so the learning outcomes, you'll be able to understand the anesthesia breathing system, and you should be able to differentiate between the different anesthesia breathing systems and their uses in clinical anesthesia practice. So those are the basic things we're going to do today. So by way of introduction, look at the diagram on the right of the screen. It depicts the anesthesia breathing system, also known as the breathing circuit, which is the link between the anesthetic machine. We had discussion about anesthetic machine last 2 weeks. This is anesthetic machine and the patient, through which the anesthetic gases that are being delivered by the anesthetic machines are being delivered to the patient's airway. So basically, all of this, all right, refer to the anesthesia breathing system or the anesthetic breathing circuit. All right, the functions of the anesthesia breathing system delivers.
Sorry, Prof. Your screen is not moving. Your screen is not moving.
I'm already on the third slide. It's not moving.
Yes, Prof, it's not moving.
Okay, let me see. Can you see now?
Yes, Prof.
Yes, sir.
Did you get to this one? Did you see this? Did you see the introduction?
We are only able to
No.
see the introductory part.
Where did you stop seeing it?
Just the first one, the first slide. The breathing circuits.
Okay,
We didn't even see the outline. We didn't even see the outline.
Really?
Yes.
Okay. Yeah. Now the outline, did you see that? This is the outline now?
No, it's not showing yet. We are still on function of the anesthesia breathing system.
You are not on slideshow, Prof, sir. Maybe if you put it on slideshow.
Oh, now what to do? Are you seeing the functions of the anesthesia breathing system?
Yes, Prof.
Okay, fine. This is where I am.
We didn't see the outline.
This is the outline. Can you see it now?
No, Prof, it's not moving.
James, what's happening today?
I think they are requesting that you have from the first slide, you are now on the fifth slide. They have not seen the fourth, third, and the second slide.
Let me restart again. Okay, where are we? Can you see I'm on outline now?
Yes, we can see.
Okay.
Can you try to click on the next to see if the slides are moving?
Do you see learning outcomes?
No.
Sir, we are still on the outline.
Yeah. What's happening today? I don't know what's happening.
Can you click on the slideshow?
I'm on slideshow. I've done slideshow.
Because we are still on the outline, the slide number 2.
My God.
Yeah, it's now moving. We are on the
It's
function.
moving now?
Yeah, we are on the functions of anesthesia breathing system.
Okay.
Can you try to move back to see if it's working also?
Can you see classification?
No.
Oh, we
Still
cannot.
functions.
I've gone back to introduction. Can you use introduction?
We are still on the functions of anesthesia.
Oh, yeah. Yeah. What's happening today? What can you see?
We can see that you are trying to, your screen sharing. You are trying to share the screen.
Oh, yeah. What about now?
We are on the classification page, slide number 6.
Okay, let me go back a little. Oh, is it moving at all?
No. Maybe you just do it manually by placing on the left-hand side of your slides.
What about now?
You have stopped sharing.
Yeah.
We can now see the functions of the anesthesia breathing system.
Did it move? I just pressed.
Yes, we are in the classification slide.
Is it moving?
Yeah, it's now moving.
Okay.
Yeah, it's now moving.
Okay. Let me go to slideshow and see. I don't know what's happening here. Okay, sorry for the hitches. Let me go to slideshow whether it will. Okay, are you still seeing?
Yes, we are in the classification slide.
Okay, I'm on the functions now.
No, it's not moving.
I think when I put it on slideshow, that's when it's not moving.
Okay, maybe you can use it now.
What about now?
It is moving.
On the classification slide. Yeah, it's moving.
Okay, I think we should use it this way. I don't know why the slideshow is not working. Okay, so like I said, the anesthesia breathing system is the link between the anesthetic machine and the patient's airway, all right, through which your anesthetic gas mixture is being delivered to the patient. So all of this comprise the anesthesia breathing system. So functions, number one, the anesthesia breathing system serves to deliver gases, anesthetic gases to the patient, removes expired gases, and controls the temperature and humidity of the inspired mixture. So the anesthesia breathing system does much more than delivery anesthetic gas mixture to your patient. It removes the expired gases, helps to control the temperature and humidity of your inspired gas mixture. All right. It also has a function to allow spontaneous, controlled, or assisted breathing. It also serves as a port for gas sampling to monitor airway pressure, flow, and volume monitoring. So the anesthesia breathing system is critical in safe delivery of anesthetic gas mixture. All right, so classification, some of these things are obsolete, but for historical relevance, we'll just mention them. So classifications of the anesthesia breathing system, we have the open system. All right, the open system here, there's no reservoir bag, no functional rebreathing of expired gases, no tubings, no valve. All right, the important thing here is that the fresh gas flow is from the atmosphere. All right, these systems include the insufflation and the open drop anesthesia technique. And sometimes we use this system in pediatric age group. All right. Now, the Schimmelbusch mask, that is what you have on the right of the screen. All right. Is usually placed over the patient's upper airway, and you put a layer of gas, all right, on the Schimmelbusch mask, and you pour your anesthetic agent, the liquid anesthetic agent, upon it, all right, and the patient inspires, the patient breathes in, the more the patient breathes in, it takes in the liquid vaporized anesthetic, inhalational agent. So it is the breathing and the mixture with the atmospheric air that vaporizes the anesthetic inhalational agent. So this is how it works. So this is known as open drop anesthesia. All right, because the patient breathes in the anesthetic, the inhalational agent, all right, through a gauze that is placed over this this Schimmelbusch mask. Okay, so this is the open example of an open system, and this is the system that your draw over vaporizer also uses. All right, because the concentration of your inhalation agent that the patient inspires is dependent solely on the patient's ability to breathe. And the advantage here is that, so if there is overdose, or you have excess anesthetic liquid being in here, the patient stops breathing and inhalation stops. Inhalation of the anesthetic liquid also stops. Okay, so we have the semi-open. Like I told, we have open, semi-open. The semi-open here have reservoir bag, no functional rebreathing of expired gases, and it has a very high fresh gas flow. All right, so the Mapperson breathing system we're going to be looking at as we continue all belong to the semi-open system. Now we have the semi-closed. All right, the semi-closed. Here, the semi-closed have a reservoir bag. There's a partial rebreathing of expired gases. There's unidirectional valves, and this one encourages low fresh gas flow. Now, a lot of times we've talked about low flow anesthesia. I'm sure you are familiar with that. All right, so both the semi-closed and the closed system allows low flow anesthesia. The closed system have a reservoir bag. There's total rebreathing of expired gases. The fresh gas flow, the beauty of here is that there's conservation of fresh gas flow because the fresh gas flow is equal to the uptake. All right. This system includes the circle systems when your adjustable pressure relieving valves is closed. All right, so this is just a summary of the classification I mentioned before. The open system, just like the insufflation and the open drop anesthesia, the fresh gas flow. On the basis of fresh gas flow, the fresh gas flow is from the atmosphere. In semi-open, there is high fresh gas flow, but there's no rebreathing of expired gases. In semi-closed, we have low fresh gas flow, there's partial rebreathing, and in closed system, the fresh gas flow is equal to the uptake of the gases by the patient, and there's total rebreathing. So just for you to just understand this, just summarize it. Open, fresh gas is from the atmosphere. There's no rebreathing at all. Semi-open, there's high fresh gas flow. That is, excuse me, that leads to a lot of wastages of anesthetic gases, and there's no rebreathing. The semi-closed and the closed have rebreathing. The semi-closed partial and the closed is total. All right. So this is important for us to remember. All right. There is another example. All right. You can just use this example to bring all of this to reinforce the learning. All right. Open, no reservoir bag. There's no rebreathing. An example is open drop. Semi-closed is what we just semi-open, then semi-closed. All right. So, what are the characteristics of an ideal breathing system? An ideal breathing anesthesia breathing system. Remember the A, B, C, D, E, F. All right. A, it should be able to deliver intended inspired gas mixture and to protect against barotrauma. B, it should have option for spontaneous control assisted breathing in all ages. C, carbon dioxide and waste gases elimination should be effective. All right. D, it should minimize, dead space should be minimized, all right, to reduce the work of breathing of the patient. E, it must be efficient. Efficiency in terms of fresh gas flow and uptake. So the closed system is an efficient system because fresh gas flow is equal to the uptake. Fresh gas flow should be low, all right. Humidification, you should have facility for humidification and warming of your inspired gases to reduce the risk of hypothermia in your patient. Obviously, it should be inexpensive, all right, simple and safe. And the last one, it should have lightweight, excuse me, and low resistance to gas flow, all right. So what are the components? Let's go back to the first slides we said. So these are during the introduction, I told you that all of these make up the anesthesia breathing system. So we're going to be looking at each of the components of the anesthesia breathing system in subsequent lectures. So the first one, corrugated tubings. All right, corrugated tubings, can be reusable. All right, when it's made of rubber. I remember when I started anesthesia training, we used to have rubber tubings. I don't know how many centers still have rubber tubings. All right, the disposables are made of plastic, and I wonder how many of us dispose our tubings after anesthesia. All right, the tubings, they connect the other components of the breathing system to the patient. All right, remember it's corrugated because it allows flexibility and resistance to kicking. So that is the corrugation there, is to increase flexibility and resistance to kinking. When I take medical students to the OR, I usually show them, I ask them or somebody to press or step on the corrugated tubing, and you'll see that it will not stop the flow of anesthetic gases. So that is why it is corrugated. And also it's made of plastic tubings so that it will be lightweight and low resistance. Each component of the anesthesia breathing system is specifically designed to fulfill specific functions. All right. So the tubes are of large diameter, about 22 millimeters, and it serves two purposes. All right, it serves to provide low resistance to flow of gases, and secondly, it serves as a reservoir of anesthetic gases. And that's why sometimes after you have switched off your inhalational agent, your vaporizers, there's still some degree of anesthetic gases in your tubings. So it serves as a reservoir of anesthetic gases. Those are the two functions of your corrugated tubings. The second one is the fresh gas inlet. We're going to be looking at it as we go on. All right, the fresh gas inlet, this is where, all right, the fresh gas from your anesthetic machine enters the breathing system. All right, the gases from the anesthetic machine enters through the anesthesia breathing system through an inlet known as the fresh gas inlet. All right, and the position of your fresh gas flow in relation to the patient and your anesthetic machine determines the performance of the Mapperson circuit. We're going to be looking at that as we go on. Two things are very crucial in classifying Mapperson system: the position of the fresh gas inlet and your APL. All right, we determine the classifications and the functionality of the different Mapperson breathing system. Now we have the reservoir bag. I hope you can picture it as we mention in each of the components. The reservoir bag, all right, serves two purposes also. All right, number one is a means of generating intermittent positive pressure ventilation. That is when you squeeze it, and it also serves as a reservoir of anesthetic gases. Okay, and very important single-based answer question: the compliance of the reservoir bag increases as its volume increases. All right, so this is important. And reservoir bags can come in different sizes. We have the pediatric sizes, and adults can vary from 3 to 5 liters. The adjustable pressure relieving valve or limiting valve, also known as the pop-up valve or exhaust valve, whatever you call it, or relief valve, or the overspill valve. This is crucial in the anesthesia breathing system because it allows the venting of anesthetic gases, all right, when the pressure is too high. It also allows the expired gases, all right, to leave the system, okay? And know that it's a one-way valve and it's adjustable, all right? And the pop-off is spring-loaded. So the spring adjusts the pressure required to open the valve, all right? Another very important thing about APL is that during spontaneous breathing, the APL valve should be left fully open to reduce resistance to breathing by the patient. And while you're doing controlled breathing, it is partially closed to allow buildup of pressure, which is necessary to generate your intermittent positive pressure ventilation. All right, so we go to the Mapperson system. All right, and I said that Mapperson system, they belong to the semi-open anesthesia breathing system. Okay, this was designed by William Mapperson in 1954. All right, so this system incorporates some devices into the anesthesia breathing system that is designed first and foremost to provide control flow of anesthetic gases. Remember that in the open drop anesthesia or insufflation, there's no control of the flow of anesthetic gases being delivered to the patient. So the Mapperson system is designed in such a way to provide a control flow of anesthetic gases. Number two, all right, to provide control of depth. So if you're able to control the flow of anesthetic gases, you'll be able to control the depth of anesthesia. And number three, which is very important, is to prevent pollution of the theater environment. So these are the things that Mapperson had in mind in designing the Mapperson breathing system. And I mentioned before the relation of the location of the components, especially the fresh gas flow inlet and the APL, determines the classification and performance of the Mapperson system. All right, so the Mapperson system is classified with letters. So the class A, and this is very crucial, just pay attention. All right, the class A Mapperson system is also known as the McGill circuit. You can see it both on the right and the left side of the screen. Okay, here, A. Let me just quickly give you, an insight, something to just help you to remember. In Mapperson A, the McGill system, the APL valve is close to the patient side. All right, is on the patient side, the APL valve. is on the patient side, APL, all right? So while the fresh gas flow is located close to the reservoir bag, all right? It is efficient for spontaneous breathing because the required fresh gas flow is equal to the patient's minute volume. So two things I want us to remember about the McGill circuit, all right, is that the APL valve, this is the APL valve, is close to the patient, okay, while the fresh gas flow, all right, is close to the anesthetic machine that is far from the patient, all right. So this is how it functions. And number two, it is efficient for spontaneous breathing, okay, because during spontaneous breathing, the fresh gas flow that is required is equal to the patient minute volume, your tidal volume times the respiratory rate. Then we have the Coasia system, okay? The Coasia system modification or the Coasia modification of the Mapacin A is known as the LAC circuit, LACK, all right? Now, the modification here is that it is designed to facilitate scavenging of the expired gases. It functions similar to McGill, but the APL is located at the machine end, all right? And we have two tubings. Let me just do this. Look at, this is here. This is the LAC system. It's known as the Coasia modification, all right? The fresh gas flow of the LAC system passes through the outer, wider tube, while the expired gases pass through the smaller inner tube. So there are two tubes. The expired gas passes through the outer, wider tube. The reason is to reduce resistance to flow, while the expired gases pass through the smaller inner tube. All right. The disadvantage includes that the inner tube can kink or disconnect. Okay. A fresh gas flow of 70 mil. These are single-based answer questions. All right. The fresh gas flow of 70 mil per kg per minute is required in this system to prevent rebreathing. Anything less than 70 mil per kg per minute of fresh gas flow will lead to rebreathing. Note, just like the McGill Mapacin A, it is very efficient for spontaneous breathing. Okay, the Mapacin B for both, okay? A for APL valve is close to the patient. B is both the fresh gas inlet and the APL valve are close to the patient. This is the fresh gas flow. This is the APL valve. This is the patient side. So for you to remember class B, know that both the fresh gas flow here and the APL valve are close to the patient end. Okay, high flow of gases is needed to prevent rebreathing, just like the LAC system, and it's no longer used in modern day anesthesia except during emergencies and for resuscitation. But note, like I mentioned, class B, both the fresh gas inlet and the APL valve are close to the patient. Class C, also known as water to and fro circuit. All right, know that the C there is no corrugated tubing. C, no corrugated tubing. All right, so there's no corrugated tubing Mapacin C. The fresh gas inlets and the APL are close to the patient's end, just like Mapacin B. But the difference here is that there's no corrugated tubing in water to and fro circuit, also known as the class C. It is ideal for spontaneous ventilation, but it requires two times the patient's minute volume. Useful for emergency resuscitation. Yes, let's go to the darling of the Mapacin system, the Bain circuit. All right, the D. The important thing here is that the APL valve is distant from the patient. The APL valve this is the APL valve here. All right, the patient end is here. So the APL valve D is distant from the patient but close to the reservoir. All right, so this is how I teach the medical student for you to remember. For class D, the APL valve is distant from the patient. All right, and it is more efficient for controlled ventilation as it requires 1 to 2 patient minute meaning ventilation. Just like the Mapacin A, the McGill circuit, it also has the coaxial modification, just like the one you see below. The fresh gas flow is located inside the breathing tube. Okay, then we have, all right, how do you check the base circuit? All right, it's important when we are doing our anesthetic checklist before we start induction of anesthesia at all. We want to check all the different components and checking for the base circuit for a leak. What you do is you close your APL and you activate your oxygen flush, all right, the button. If the inner tube is intact, all right, the Venturi effect will cause gas to be sucked out of the bag and the bag will collapse. That means that there is no leakage, the inner tube is intact. But if the inner tube is damaged, the stream of oxygen will be directed to the bag and it will fill up. That shows there is leakage. So this is a simple way to check for leakage of your vein circuit. All right, there are a lot of advantages. I won't go over them. All right, but the beauty of it is that your vein circuit, your class D, allows both spontaneous and controlled ventilation. All you need to do is to change your APL valve either to open or to close. All right, it has access limited area. All right, especially if you want to do sedation for MRI. All right. Inspired fresh gas is warmed because it has two tubings. The inspired gas is warmed by the warm expired gases. There's no accumulation of expired gases close to the surgical feed. It has good convergence system, low resistance. Additional drag on ETT is limited as compared to the McGill circuit. All right. Connection to the ventilator is easy, and kinking or disconnection of the ET tube is easy to detect because the outer tube of the coaxial vein circuit is transparent. It also has a lot of disadvantages. If you see my mnemonics, when you get the slides, you go through it. I don't want to go because our time is fast spent. All right, but know that patient below 20 kg, all right, you can't use the vein circuit. All right, sometimes assembly then can be wrong. All right, and all that. So you go through let's just move on. The class E system, all right, what we know as the Aristides, all right, it resembles the Mapacin D, the base circuit, but know that it has no reservoir bag, it has no valve. So class E, everything is absent. All right, class E, everything is absent. There's no reservoir bag, there's no APL valve attached to the breathing system. All right, why? Because it is designed to produce low resistance to gas flow and is to be efficient for spontaneous breathing. The very significant importance or significance of Aristides is that it is used or useful in children with a weight of less than 25 kg. So between 20 and 25 kg, you use the Aristides. All right. So everything is absent here. When I mean everything, I mean the reservoir bag and the APL valve is absent. All right, so class F, all right, the Jackson-Rees modification, all right, similar to the Aristides, but it has a reservoir bar connected. So when you have a reservoir bar connected to your Aristides, you have your Jackson-Rees modification, which is the class F, all right? The reservoir bar is connected to the end of the tube to allow for controlled ventilation. That is the importance of that reservoir bag here. But F allows free flow of gas because there's no valve. It has a reservoir bag, but it has no valve. F to allow free flow of gases. Remember, class E, everything is absent. There is no reservoir bag and there is no APL. Here, there is a reservoir bag connected to allow for controlled ventilation, but there is no APL valve to allow for free flow of gas as it passes to the patient. All right. Are you still there? Are you still following me?
Yes, sir. Yes, sir.
Okay. Now look at the advantages and disadvantages between E and F. You just read that, all right, so that we go on. Now we have the universal breathing system. I don't know how many of us have it in our centers, but this is very, very important. We know that we call it the Humphrey ADE circuit, all right, also known as the Mapperson ADE circuit. The beauty of it is that it combines the advantages of Mapperson A, Mapperson D, and Mapperson E systems. All right, so you have three breathing systems in one, known as the Humphrey ADA. Yoruba people call it Humphrey Ade circuit. Okay, Ade circuit. It has the advantages of A, D, and E system. All right, the circuit to be used is determined by the position of the selector valve and which of the bag connector is used. This is crucial. For instance, if you have an adult you want to anesthetize and you want to use the Bain circuit, all right, all you need to do is that the lever, you just put the lever down, the lever goes down. This is the lever, you press the lever down, all right, but the back, okay, you press the lever down, you have your Mapperson D circuit ready to be used. For Mapperson A, especially your McGee circuit for spontaneous breathing, A, the lever is up and the bag is connected. For D, if you want to use Mapperson D, the lever is down and you connect the bag too. And for E, it's same with D, but you remove the bag. All right? Do you understand that? I hope I'm making it clear. The advantage of Humphrey ADE circuit is that it can function either as Mapperson A, Mapperson D, or Mapperson E. You decide which of the circuit to be used based on your patient's characteristics. For Mapperson A, for spontaneous breathing, your McGee circuit, the lever here, the valve, the lever here, I hope you can see that, you raise it up, all right, and you connect bag one. Okay, you have your Mapperson A. For Mapperson D, you press the lever goes down, and bag two is connected. For Mapperson E, your Aristide piece, the lever is down, just like your Mapperson D, and the bag is removed. So you have your Mapperson E, your Aristide piece. All right. Okay, so this is the summary of the Mapperson A system. Can we go over them again? Class A, where is the APL valve? Is on the patient side. APL valve on patient side. Class B, APL and fresh gas flow inlet, they are on the patient side, both. Class C, corrugation is absent. Class D, the APL is distant from the patient. Class E, everything is absent. That is no reservoir bag and no valve, no APL valve. And class F is like class E, all right? It has a reservoir bag but no valve, so it allows for free flow of gases. So we're going to look at all right, I think I have it in the question. Okay, for it, oh, this one is labeled. I like this question. I'll just put the diagram here without labeling it, and I'll ask you to identify each of the Mapperson system. All right, to identify A. APA valve is close to the patient. You can see it here. B, both the fresh gas flow and the APL, they are close to the patient side. C is like B, the fresh gas flow and the APL is close to the patient, but there are no corrugated tubings. D, the APL valve is distant from the patient. You can see it here. E, everything is absent. No reservoir bag, no APL valve. F, there's free flow. All right, there's no APL valve, but you connect your reservoir back. All right. Okay, any question thus far on this? We just look at, all right, this is just for our consumption. And this is important to determine what fresh gas flow are needed for each of the systems. For instance, the Mapacin A, you require about 70 to 100 mil per kg per minute. All right. And this is why we say that it is more efficient for spontaneous breathing. But for Mapacin D, okay, especially for spontaneous, you require about 150 to 200 ml per kg per minute. So it's not efficient for spontaneous breathing, but for controlled breathing, you require about 70 to 100, which is efficient. All right. For your Jackson Rees modification, your Mapacin F, you require about 2.5 to 3 times the minute volume of the patient. So you just see that, especially comparing Mapacin A and Mapacin D system. Okay, so these are the table just to give you, to summarize all that I've been saying, just familiarize yourself with it. All right, so the other thing we're going to talk about is the circle system. Remember, when we started, we said there are 4 classifications of the anesthesia breathing system. We have the open, semi-open, semi-closed, and closed. All right, the circle system is an example of a closed system where the fresh gas flow is equal to patient's uptake. All right, and it is designed to avoid wastages of anesthetic gases and to reduce theater environment pollution. Now, how does it do that? By incorporating a carbon dioxide absorber. All right, this helps to prevent rebreathing of expired gases. All right, it prevents rebreathing, because in the closed system, without the carbon dioxide, remember we did say that in closed system there's rebreathing, and if there's rebreathing of carbon dioxide, you're going to have hypercarbia, carbon dioxide narcosis, and all other problems that are related to increased concentration of carbon dioxide in the system. So to prevent this, there's a carbon dioxide absorber that has been incorporated into the circuit system. And there are 2 types, but the most common carbon dioxide absorber is a soda lime. All right, I'm sure we are familiar with it. All right, the soda lime is contained in a canister, and it consists of 4% sodium hydroxide, 1% potassium hydroxide, less than 20% water, and the remaining is calcium hydroxide. So the bulk of the constituent of soda lime is calcium hydroxide. All right. And in addition, you have small amount of silica or kesegol, all right, that are added for hardening and to reduce the formation of dust. The beauty of soda lime, with the greatest component being the calcium hydroxide, is its ability to absorb as high as 23 liters of carbon dioxide by 100 grams of the absorbent. This is very high, all right? Ability to absorb as high as 23 liters of carbon dioxide by 100 grams. All right, so you can imagine if you have 1 kg of the absorbent in your canister, you can imagine how many liters of carbon dioxide that can be absorbed. All right, it is very efficient carbon dioxide absorber. All right, not because the water is a chemical reaction. Carbon dioxide reacting with calcium hydroxide. All right, it's a reversible reaction. The water and sodium hydroxide that is required for the initial reaction of carbon dioxide are regenerated. All right. I used to draw this chemical reaction when I'm teaching medical students. It shows it's a reversible reaction. All right. What is required for the initial reaction is generated at the end of the reaction. Number 3 advantage of the soda lime is that the reaction between calcium hydroxide and carbon dioxide is exothermic. That it produces heat. So it heats up your inspired gases and reduces the risk of hypothermia. All right. And number 4 is that the water that is produced at the end of the reaction serves to humidify the system. So we have 4 basic advantages of your carbon dioxide absorber in the circuit system. And very importantly is that the carbon dioxide canister has different types of indicators that are added to show you when your carbon dioxide absorber is finished. All right, it's getting used up. All right, depends on what you have. All right, there are so many colors. Most of the ones we have is earthy violet. All right, when it's fresh, it's white and becomes purple when it's exhausted. So next time you go to theater, look at your soda line absorber and check whether it's still fresh or it's almost being used up. This is important because if your carbon dioxide absorbent is used up, your patient carries the risk of breathing carbon dioxide. So you can have carbon dioxide narcosis, and sometimes that's the reason why the patient does not wake up after anesthesia. There are other different types. We have the phenolphthalein, all right, which is white when fresh, becomes pink on exhaustion. Clayton, Durasop, and so many of them. So it depends on the ones you have in your center, but just make sure that you're able to differentiate between when your carbon dioxide absorber is fresh and when it's almost being used up. The second type of carbon dioxide absorber is the barrel-line, all right? But it's when desiccated, the disadvantage is that one, when desiccated, it reacts with sevoflurane, all right, and it can produce heat that can give you a temperature in the excess of 400 degrees centigrade. So there is high risk of fire explosion with barrel-line. Number 2, it has reduced capacity to absorb carbon dioxide, your soda line. All right. Degradation of volatile anesthetic by dry absorbent can also lead to carbon dioxide poisoning, especially when used with sevoflurane. All right. So, in addition, sevoflurane degradation can also lead to compound A production, which has been shown to be nephrotoxic in animal studies. Please, can you mute your mics so that we don't get distracted, please? Please, James, can you mute this mic for me? All right. I used to see my slide. Okay, so now this is just a table comparing both soda lime and barrel-line. Okay, now if you look at the capacity to absorb carbon dioxide, soda lime has about 14 to 23, ability to absorb 14 to 23 liters of carbon dioxide, unlike barrel-line that has the maximum capacity of 18 liters. All right, they have the same indicator dye. All right, and the method of hiding, like I mentioned, is silica. All right, for soda lime, why it is water crystallization for barrel-line. I remember during residency, they used to ask us these questions a lot. I don't know if they still do. They can ask you to compare and contrast the different carbon dioxide absorber in your circuit system. Okay, so the components of your circuit system is as shown. All right, we have the 2 unidirectional valves preventing rebreathing. We have a fresh gas inlet, the AY piece to connect to the patient reservoir bag, your APL valve, and a low resistance interconnecting bag. You can see it on the right side of your screen. Okay. Yes, this is the end. I have some likely exam questions, but because of time, we may not be able to go over them. But look at some of the questions I've asked my students in time past, especially undergraduates, classify the different types of anesthesia breathing system and give an example each that carries 4 marks. All right, if you list the 4 components of anesthesia breathing system, that carries 2 marks. Now, if you list 4 types of mouth-passing system and their major differences, that gives you 4 marks. All right, I think we should stop here this evening. Any questions, any comments? We may start. We started late, it's already after 9 in Kigali. Any questions, any comments? I can't seem to see. Okay. Yes, any comments, colleagues? Did you people hear me?
Yes, we are hearing you, Prof. Sir.
Yes, sir. We heard you, sir.
Okay. You are hearing me. Any questions, any comments?
There are some comments on the chat box.
Sorry?
I can see there are some comments
Please,
on
if
the
you
chat.
want to talk, can you unmute your mic so that we can hear you?
Hello, Prof.
Yes.
I can see there are some comments on the chat box.
I can't seem to see my chat. That I don't know. I
Okay.
don't know what's happening. I can't seem to see my chat.
Okay, there is one from Modesta. Thank you, Prof, for the presentation and detailed knowledge of breathing circuit imparted this evening. What examples of semi-closed breathing circuit?
Okay. All right. Any other question? Anybody wants to try that? Let's go back to our. Let me see the slide on semi-closed. Where am I? So what's the example? You know, some people think about semi-closed. The important thing there about semi-closed is that there's partial rebreathing, all right? And semi-closed, most of the times, people talk about low flow anesthesia, and unlike the most of the mouth-passing system, is designed to follow the semi-open, but there are some modifications to the systems that allow partial rebreathing, and the idea is to have more efficient use. Some of the anesthetic machines actually allow a flow rate, a gas flow rate of about 1 to 2 liters per minute. Excuse me. So those are the ones that are examples of semi-closed. All right. I know there's one theater I worked before that we really had, especially with the introduction of health insurance. Most of the insurance companies, they don't want to pay for so many things. They want to reduce costs. So there's been a lot of move on having semi-closed circuits, all right, that allows for very low fresh gas. I hope that is the answer the person wants. I can't seem to see the chat. I don't know what's happening today. Answer your question. Are you happy with that question, or you want more clarification? Fatima, you want to say something? Because I see you unmuted. Any other question? James, any other question on the chat? I can't see them.
Okay, there's another question from Sabrine. I wish to know the difference between semi-open and semi-closed.
I think I just mentioned that now.
Yes.
The major difference is that there's no rebreathing in semi-open, and in semi-closed, there is partial rebreathing. In closed, there's complete rebreathing, and that is why you need a carbon dioxide absorber for the closed system. For the semi-closed, there's partial rebreathing, but in semi-open, no rebreathing is allowed in the system.
Also, there's a question from Dr. Nduka. Is Ambubag a type of Mapleson C breathing system?
Ambubag.
Yes.
Ambubag, it's not part of the Mapleson system. Ambubag is actually a component of anesthesia and emergency equipment. It's part of airway equipment in actual sense. So Ambubag is not part of Mapleson system. Mapleson system incorporates different components. All right, like we mentioned before, the tubings, the reservoir bag, the APL. So Ambubag is not strictly an example of Mapleson system. Okay, but your Ambubag connected to your class B, your water, your what's it called? Your class B, all right, can class B Mapleson system when you connect to Ambubag, but it must have the other component, like we mentioned before. The APA valve must be there to make it Mapleson B, but Ambubag in itself does not qualify to be a Mapleson breathing system. Why are people not talking today? People are only chatting, no talk. Dr. Mashava, good evening, man. How are you?
Fine, thank you, Prof.
Yeah,
Thank
we're
you
doing
for the
anesthesia
beautiful
today.
recap on the breathing systems. Yeah,
Thank
I
you.
think it's
Thank
well
you.
covered. I have no additions.
Thank you very much, man. Thank you. All right. If there are no other questions, no comments,
No
James,
additions.
any other thing
Thank
on
you.
the chat?
That's all from the chat box, Prof.
Okay. All right. I think no more comments. Like I said, is a popular topic. I'm sure we're all familiar with it. But let me ask a question. Does it this lecture, does it add to what you know before, people?
Yes, sir.
Yes.
Yes, Prof.
Okay.
Yes, sir.
All right. So, okay, Dr. Nduka. Okay. So somebody quickly wrap up the different Mapleson A to F. Let me be sure that you got what I said from the little mnemonics that I gave you now. Quickly, somebody wrap up class A to F. What are the differences? Dr. Nduka is your name that is showing very much here. Quickly, what is Mapleson A?
Thank you very much, for Mapleson A. The APL valve is close to the patient.
A, beautiful.
For
B?
Mapleson B, both APL valve and the fresh gas inlet are close to the patient.
Beautiful. C?
For Mapleson C, there is no coagulated tube.
Beautiful.
But just like B, but no coagulated tube. Corrugated tube, rather. Then for Mapleson D, the APL valve is distant from the patient.
Beautiful.
And then for Mapleson E, the everything is absent. Everything is absent.
What does this everything mean?
The reservoir valve, the APL valve, they are absent. For F, there is flow. The reservoir valve.
Okay. Mapleson F?
Mapleson F is there's a free flow. That is Mapleson D with a reservoir valve.
Bridget Bassi, you are disturbing us. Are you talking? Please, can you mute yourself? Dr. Nduka is talking. Nduka, sorry, continue.
Okay, so I said for Mapleson E, everything is absent. The APL valve and the reservoir bag are both absent. Then for F, there is flow. It's Mapleson reservoir bag.
Beautiful. What about the Humphrey ADA system?
Okay, it's a combination of both that is a system that combines the advantages of both Maplesin A, D, and E. So if you want to use Maplesin A, the switch is up, and then there is reservoir bag, and then for D, the switch is down with the reservoir bag, but then E is the same down, but there's no reservoir bag, sir.
Thank you. You passed 100%. All right, good. So let's call it an evening, everyone. Dr. Mashaba, is there any announcement, ma? James, any announcement? Okay. I don't think there's any announcement. James, are you there?
Yes, Prof. Yes, Prof. I have no announcement.
Okay, thank you. Guys, please pray for us in Rwanda. God is in control, and everything will be under control very soon. Thank you so much. Have a wonderful evening, everyone.
Thank you, Prof.
Thank you, sir.
Thank you, sir.
Thank you, Professor.
All right.
Thank you, Prof. Well received lectures. Thank you, sir.
Thank you, Prof.
Thank you, sir.
Thank you, Prof.
Thank you. Yeah.